Premixed 25 or insulin NPH 50/50 or insulin NPH 30/70. The treatments were switched after 12 weeks and the dose adjusted to achieve a blood glucose of 7.8 and 2 hours of 10. This was the study design which worked out, and thereafter, as you can see, the insulin lispro mixture BID versus human mixture BID, 2 hours postprandial blood glucose response. As you can see, the red bars here represent the lispro mix, whereas the black bars represent. So in terms of the postprandial, which was the primary objective, in all these situations, whether all patients type 1 diabetes or type 2 diabetes, lispro mixtures, as expected, did better than the standard regular human insulin mixtures. The nocturnal hypoglycemia risk, as you can see, the lispro mix had significantly lower hypoglycemic risk compared to the regular insulin which we are used to. So when compared with human insulin mixtures in a BID regimen, there was reduced postprandial blood glucose control, there was lowered risk of nocturnal hypoglycemia, and it provided convenience of injecting immediately before the meal compared to 30 to 45 minutes for human insulin. In another study, they looked into the patients following compliance in terms of injecting the regular insulin 30 minutes before that, and it was found that only 50% of them were complying with the time regulations, and many of them were injecting the insulin about 20 or less minutes before their meals, which will increase the risk of hypoglycemia. The other lispro mix 50, as I mentioned, was formulated based on the 24-hour insulin requirements, and thereafter it was compared to regular insulin NPH 30/70 BID. The lispro mix 50 TID is convenient in terms of educating your patient how to adjust the dose and to give a dose before each meal. So the primary objective again was the mean blood glucose change, and the secondary objective was A1C and 7-point blood glucose control and hypoglycemia. It was a single-center study in which the 2 arms were 12 weeks cross-hearted, and as you can see, in insulin lispro mix 50 TID versus the endpoints blood glucose change was significantly better in the low mix 50 TID compared to the usual 30/70 we use. That again, sometimes it goes with the culture as well. In many of the Asian countries in particular, the main meal of the day is lunch rather than dinner. With the BID regimen, usually the post-lunch excursion is even not noticed. And if this is not covered, you won't expect a good postprandial control, and you won't expect an improvement in A1C as well. So as you can see, in the comparison, the 2 hours postprandial blood glucose at baseline and endpoint between the 3 arms, as you can see in the baseline and thereafter in the insulin ones, and it was significantly different after lunch and after dinner, more so appears after lunch as well, because when you're injecting 70/30 BID, the lunchtime excursion is not covered at all. The achievement of the A1C towards targets is very different. As you can see, it was 8.4 in the baseline. It reached 8.1 after 12 weeks, and thereafter 7.6 in the lispro mixture 50 TID. The hypoglycemia rate again was not very significant between the two groups. So summarizing that when compared with Humulin 30/70 BID, lispro mix 50 achieved a greater decrease in mean blood glucose, a greater reduction in A1C, was associated with the smaller postprandial blood glucose excursion, and improved the overall glycemic control. Thereafter, we go the standard, what is called the physiologic insulin replacement, in which you go on the basal bolus regimens. And obviously, this is termed as the best regimen available, but sometimes with 2 types of insulin, it may not be very easy to educate the patient in terms of adjusting the dosages and achieving the target control in terms of letting and educating them. So in this study, insulin lispro mix 50 TID was compared with the basal bolus insulin regimen, in which the prandial insulin used was another analog, lispro, and the basal was used as a glargine. It was a 24-week multi-center randomized open-label trial in which the patients were recruited with inadequate glycemic control on glargine and oral therapies. So because they were already on glargine with the basal insulin, they needed a prandial insulin to be added. They were randomly assigned to lispro mix 50 or basal bolus treatment regimen using glargine and preprandial lispro TID. The dose was adjusted to reach a preprandial of less than 110. The patients continued with metformin and or the oral agents, but sulfonylurea were stopped. The low mixture 50 patients not reaching FPG target could switch pre-dinner injection to the low mix 25. Sorry. As you can see here, the comparison in terms of the change in the A1C between the two groups was not significantly different. It achieved -2 here and -1.87 here. And you can look at the glycemic excursion 7-point, which was monitored in the two groups at the baseline, and thereafter at the end point was following much the same line in the two groups. In terms of the A1C monitored over a 24-week period, again, there was no difference between the two regimens. Whereas in one regimen, basal insulin and the prandial insulin were different, requiring a different adjustment, whereas in this regimen, the same Humalog Mix 50 was used 3 times, and patients were advised how to monitor and adjust their dose. So when compared with human insulin mixtures, it reduced the postprandial blood glucose control, lowered the risk of nocturnal hypoglycemia, and provided convenience of injecting before the meal. The algorithm used in this study based on that was recommended thereafter for clinical use in type 2 diabetes was that you have to identify the patients who may benefit from Humalog Mix 50 therapy. These are the ones who are currently on insulin regimen, and they have need better control. A1C is more than 7. Sorry. They are usually asymptomatic with a pre-breakfast of more than 110 and require 3 times daily TID pre-meal dosing per 3 meals. You divide the current daily dose by 3 and give the subcutaneous at pre-meal 1/3 the total dose of each main meal. For example, a patient on 12 units of NPH twice a day has a total dose of insulin 24 units per day, which is divided into 3 dosages of equal amounts, which is 8 units before each of the 3 main meals. The patients are advised to increase dose gradually and adjust accordingly. The oral anti-hyperglycemic medications recommended was metformin in divided doses. Other can also be maintained. Frequently, they monitor their blood glucose and adjust pre-breakfast, pre-lunch, and pre-supper blood glucose based on the assessment every 3 to 4 days. As you can see, if they've got a target range available, they don't have to change the dose, but if their pre-meal glucose level is more than 110, then adjust the preceding dose by 2 units, and if it is more than 140, they increase by 4 units. In the same way, they are easily educated to cut down on their dose adjustment. So if it is less than 50, they decrease by -4, and if it is between 51 and 79, they decrease by -2 units. So in those terms, it is compared to basal bolus regimen, easier to educate your patient how to monitor and adjust their own dose. If hypoglycemia occurs during the dose adjustment period, one has to assess whether there was a reason for that. So either you decrease the insulin dose or you can decrease the insulin secretagogue if it is being given along with that. So the patients with large fluctuations in postprandial blood glucose, for example, those caused by regular consumption of high-carb meals or foods with high glycemic index such as rice, are more likely to benefit from insulin Lispro Mix 50. The more advanced insulin deficiency indicated by severe chronic hyperglycemia and high A1C levels. So at the end of the day, thereafter, one has to see that we've got various options available for improving the preprandial, postprandial, and A1C control in our diabetic patients, but we have to assess each patient individually. And the best way to achievement those purposes is that when you educate your patient for the self-monitoring of the blood glucose, you ask them to maintain a record, even if they are doing blood sugars maybe 2 or 3 times per week, that we need a record not only of the fasting, but at least one time for the post-breakfast, another time for the post-lunch, and another time for the post-dinner as well, to adjust and optimize their insulin regimen and other agents accordingly. Thank you very much.
Thank you. Can I have both speakers with me on stage?
The South Asians I'm practicing in Saudi Arabia. The days are much shorter than the UK ones. So is there any difference in managing the patients with insulin as you practice in UK?
If I understood your question, is this specific to Ramadan Or
Yeah,
just-
Ramadan.
Ramadan,
The fasting period is less, shorter than the UK ones.
Yeah, I think, in UK it's the fasting time is increasing to about 14 to 16 hours because we're going in the summer. But in
Sometimes
terms
we
of
have-
the regime of insulin, it's the longer acting insulins that are important here because they're the ones that are going to be around the system longer. So the length of your time that you spend to fast, say in Saudi Arabia, it's going to be fixed and shorter. So I don't think you need to be so worried about adjusting that. But the reason that we use Mix 50 is for two things. One is because it's less short acting in there, which will be good for your population. And there's more fast acting there to increase some of the difference in your meal constituency of carbohydrates and sugar at that time. So I think it addresses both, and I think it's similar. We've spoken to some colleagues around the world, and they say that also is the same concept for them. And so I think that's the less shorter acting, less longer acting you have is better. So for instance, if somebody have mixed out 30, they've got 70% longer acting. So I think it's safer to have less and move to a mix 50 so that your longer acting doesn't last too long to give you the risk of hypoglycemia.
Thank you.
Any more question? Okay, maybe I can ask one or two questions. Would you like to comment on any of your experience combining GLP-1 with basal insulin, for instance?
It's an interesting question. Although it's not a licensed indication, I'm not sure about over here, but
It's off-label, yes.
yeah, it's off-label in UK also. But I must say that we have had lots of success with patients in combination of insulin and GLP-1 therapies. We have, in my books, about 150 patients on the combination. The reason behind that is some of them may not be, we use bariatric surgery a lot for weight loss, and if patients have high insulin resistance and taking a huge amount of insulin, the difficulty is trying to not give more insulin and put more weight on. So these patients are obese already. We tend to use more GLP-1 together, purely because it's a weight neutral, or perhaps it has weight loss therapy in some patients. However, I think Dr. Jabbar already said, if there's no beta cell there, then it's not going to work. But you don't know until you try in our patients. So I think you have to give it a go for 3 to 6 months, see what the response. And if the HbA1c can come down by 1%, I think you're a winner, and particularly the patient can lose weight. So I assess by the fact that you don't know how much a beta cell there is, and I give it about 6 months and see what the effect is.
We tried in particular because it is off license, particularly before GLP-1s were licensed in Pakistan. Many of our patients who are not optimizing in control and are not willing to go for multi-dose insulin. So usually, as per the usual practice, we start them on basal insulin. But they are overweight as well. So once it was licensed to be used, not with insulin, but even registered in Pakistan, I tried it in many patients in which they were already on basal insulin. So I cut down on the basal insulin dose, started on GLP-1. And in some of them, not all, it worked to the betterment that their glycemic control was better. I had to cut down on their sulfonylurea dose and the basal insulin dose particularly as well. And they achieved some weight loss as well. So in some patients it does work, and thereafter one of the measures from that perspective is that to begin with, if you start somebody on basal insulin who has got problem with both fasting and postprandial, this is not the right regimen for that person. So from that point, it does show you, okay, this is a beta cell failure already, it's too much there. But if we're seeing somebody who has got predominantly fasting hypoglycemia and the postprandial is not that bad, these are the ones who are likely to respond because you started their basal insulin a bit early than that what they needed for optimizing the control. And there may be some factor for the patient's compliance as well.
Yes. I think no more question? All right, with that, I think let's show our appreciation to the two speakers in our usual way. Thank you. All right. Thank you. Let's see you, right? Yep.